Welcome to the OxyContin Core Visual Aid Implementation Guide. This eCampus module provides valuable insights about the OxyContin CVA that can help you prepare for successful conversations with HCPs. The examples in this training module should be used in the context of a complete sales call that incorporates appropriate contextual and safety information. Throughout, you will find a representation of each page from the CVA accompanied by information that can help you maximize the impact of your presentation, such as the communication objectives behind each spread, key selling messages that can help you meet the objectives, valuable market research learnings derived from market research to help you understand the importance of our messages, and powerful questions that can transform your detail into a discussion, driving greater engagement with your decile 7 to 10 target HCPs. Please note that the market research learnings are provided for background only and should not be used as messages to discuss with HCPs. The OxyContin CVA has been updated to reflect a few changes in the opioid prescribing environment over the past year. These changes include updates to the boxed warning and important safety information, also known as ISI. There is a separate training that you have received describing this class-wide safety labeling update. However, we will also highlight throughout this reference tool where the updates have been incorporated in the CVA. Our commitment to transparency and responsibility has been brought to the forefront, helping to demonstrate that we are true partners who can help our customers navigate the current opioid prescribing environment. A very important aspect of promoting OxyContin is to reinforce Purdue Pharma's dedication to the responsible prescribing of opioids. In order to align our messaging with the current prescribing environment, we've added content including what physicians should consider before prescribing opioids, reinforcing the need for continual reassessment throughout treatment with opioids, titrating to achieve balance between analgesia and tolerability, and when and how to discontinue treatment with opioids. This revision to our story flow helps address HCP needs during each phase of their patient's journey, from the treatment decision to the management of therapy to planning for discontinuation. Before moving on to the messaging, we want to remind you to be sure to communicate the indication and safety information, that is, the boxed warning, contraindications, warnings and precautions, and adverse reactions throughout every discussion with an HCP. As a reminder, we will discuss the communication objectives behind each spread, key selling messages that can help you meet the objectives, valuable market research learnings derived from market research to help you understand the importance of our messages. Remember, these learnings are not promotional messages to be used with HCPs, and powerful questions that can transform your detail into a discussion, driving greater engagement with your decile 7 to 10 target HCPs. Now, let's begin. The front cover of the CVA is meant to capture an HCP thinking about considerations to keep in mind when deciding whether or not to initiate an extended-release ER opioid for a patient with chronic pain. Through market research, we have learned that managing patients with chronic pain with opioids can be a clinical challenge for many HCPs, and many considerations weigh on their minds when prescribing an ER opioid. Here, the HCP is deciding on an appropriate course of therapy. His thoughtful look captures how some HCPs may feel when prescribing an ER opioid. The objective of this spread is to demonstrate that abuse, misuse, and diversion of opioids is a serious public health issue. The key messages to convey to your HCPs are as follows. According to the 2013-2014 National Survey on Drug Use and Health, nearly 66%, or two-thirds of non-medical users, received pain relievers from a friend or relative. In addition, 51% of these non-medical users got them for free, without buying or stealing them. Finally, of the more than 10 million past-year non-medical users of pain relievers, only approximately 19% met the criteria for an abuse or dependence diagnosis. Additionally, pay close attention to the footnotes on the bottom of the page, as there is valuable information, including definitions that your HCPs may not be familiar with. This information should also be conveyed to your HCPs, as it helps to ensure understanding of the NSDA data presented. In market research, we have learned that HCPs are expressing more concern about liability issues associated with prescribing opioids. Some powerful questions you can ask an HCP when discussing these data are, which of these statistics, as you point to the numbers, is compelling to you, and why? What steps do you currently take in your practice to prevent these issues? And how do you educate your patients on abuse, misuse, and diversion? Page 4 of the CVA contains the boxed warnings and the adult indications and usage. The contraindications are now located on page 5. The boxed warning contains the new warning regarding the risks of concomitant use with benzodiazepines or other CNS depressants. The indications and usage contains important information for HCPs to keep in mind when selecting appropriate patients for treatment with OxyContin. Your role is to help HCPs understand the indications and usage to help them determine which patients may be appropriate for OxyContin. Also, make sure HCPs know the contraindications when assessing whether a patient may be appropriate for OxyContin. Page 5 of the CVA also lists some key considerations an HCP should take into account when deciding on a treatment plan for a patient with chronic pain. The objective with these messages is to reinforce established HCP experience with OxyContin with the statement, "Let experience be your guide." Remind HCPs that OxyContin has proven efficacy with over 20 years of clinical experience, was the first ER opioid with FDA-approved labeling describing abuse-deterrent characteristics. However, abuse of OxyContin by injection, as well as by the intranasal and oral routes, is still possible. Offers broad formulary coverage. Be sure to communicate that inclusion on formulary does not imply superior clinical efficacy or safety. Market research has taught us that HCPs acknowledge that their use of OxyContin is based on experience, familiarity, and proven efficacy. Another key learning is that when considering prescribing an opioid for the management of pain severe enough to require daily, around-the-clock, long-term opioid treatment, and for which alternatives are inadequate, HCPs value analgesic efficacy, managed care, cost, and tolerability. In your discussion with an HCP, some possible questions you may ask are, which of these statements are important to you when prescribing OxyContin for a patient with chronic pain? And what has been your clinical experience with OxyContin? Make sure that you capture and report any adverse events that HCPs may share with you according to company policy when you ask this last question. Remember, always have a balanced presentation of messages and risk information with HCPs. Earlier, we briefly discussed that opioids can and are being abused, misused, and diverted. The left side of the spread reminds HCPs to assess each patient's risk for opioid addiction, abuse, or misuse prior to prescribing OxyContin. The risks of addiction, abuse, misuse, and diversion should be considered when prescribing or dispensing OxyContin. However, concerns about addiction, abuse, and misuse should not prevent the proper management of pain. Using the right side of the spread, you should inform HCPs that OxyContin was reformulated and in 2013 became the first extended-release opioid with FDA-approved labeling describing abuse-deterrent characteristics. Discuss the summary statements about the abuse-deterrent characteristics of OxyContin found on this page. You must also communicate the information in the blue box that abuse by injection and intranasal routes as well as by the oral route is still possible. If HCPs are interested in learning more about the clinical abuse potential study, you can discuss with them pages 8 and 9 of the CVA, discussed on slides 24 and 25 of this module. There are 3 key learnings from market research that informed this spread. Awareness of the abuse-deterrent characteristics of OxyContin remains low. HCPs are more interested in knowing that an ER opioid has abuse-deterrent characteristics than the specific abuse-deterrent technology. And some HCPs perceive it to be difficult to get FDA approval for abuse-deterrent labeling. Some powerful questions to facilitate discussion are, given the current healthcare environment pertaining to opioids, what role are products with abuse-deterrent properties playing in your practice? And how do abuse-deterrent characteristics affect your decisions when prescribing an extended-release opioid? The objective of this spread is to demonstrate how the abuse-deterrent characteristics of OxyContin are expected to deter abuse via the intranasal route. Key messages to deliver here are that recreational opioid users reported less drug liking with finely crushed OxyContin compared to powdered oxycodone and finely crushed original OxyContin. They also reported less desire to take drug again with finely crushed OxyContin compared to powdered oxycodone and finely crushed original OxyContin. However, abuse of OxyContin by injection and intranasal routes as well as by the oral route is still possible. Be sure to review the details of the methodology so that HCPs understand how the study was conducted. Remind HCPs that abuse via injection and intranasal routes, as well as by the oral route, is still possible. Do not make unsubstantiated claims about the potential for abuse with OxyContin. Do not compare the abuse potential of OxyContin with that of other opioids. And always remember to have a balanced discussion of messages and risk information with HCPs. The objective of this spread is to provide an understanding of selected warnings and precautions for OxyContin not found in other spreads of the CVA during your sales calls with the HCPs. Remember, warnings and precautions can have implications for prescribing decisions or patient management, and appropriate fair balance must be used on all calls in order to have a balanced discussion of messages and risk information with the HCPs. Note the newly added warnings and precautions that inform the HCPs about the risks of concomitant use of benzodiazepines or other CNS depressants with opioids and adrenal insufficiency. Some powerful questions you may consider are you familiar with the recent change to the warnings and precautions about concomitant use with benzodiazepines or other CNS depressants? Are you familiar with the adrenal insufficiency information? And do you have any further questions related to these warnings and precautions for OxyContin? The objective of this spread is to reinforce and review who may be appropriate patients for OxyContin. Appropriate patients for OxyContin may include those with low back pain, osteoarthritis pain, or cancer pain who are experiencing pain consistent with OxyContin's indication. These patients may be taking immediate-release oxycodone and or have increasing opioid analgesic needs and may not be getting adequate pain relief or may not be tolerating their current treatment. Remember to communicate the risk information in this spread to have a balanced presentation of messages and risk information during your sales call. Market research shows that PCPs and pain specialists ranked messages describing a condition-related type of chronic pain, for example, low back pain, osteoarthritis pain, and cancer pain, highest in motivation to prescribe OxyContin. HCPs also agree that for patients who have tried and failed other pain products, prescribing OxyContin next aligns with how they use the product. To facilitate a discussion, some powerful questions to consider asking HCPs are, of these types of chronic pain just reviewed, which do you most often treat with daily around-the-clock ER opioids? And what level of analgesic need triggers your decision to prescribe OxyContin as the first ER opioid for a patient with chronic pain for whom alternative treatment options are inadequate? This spread is new to the CVA. Page 14 contains language that aligns with the current prescribing environment and considerations for prescribing OxyContin. Key messages to convey to HCPs include, opioids should only be prescribed if the expected benefits outweigh the known risks, prescribe the lowest effective dose of OxyContin for the shortest duration, and educate patients about the realistic benefits and the known risks of opioid therapy. Market research has shown us that HCPs are adhering to the CDC guideline and have begun to limit the daily dosages of opioids. HCPs indicate a change in prescribing behavior, which may be related to the CDC guideline. Purdue's perspective is that the recommendations listed on this spread are consistent with established standards of medical care, would not pose increased risk to patients, and are likely to improve the benefit to risk profile for patients. You may want to ask these powerful questions. When a patient needs daily around-the-clock long-term opioid therapy, what factors do you consider when deciding to prescribe an ER opioid? And how do you educate your patients on the realistic benefits and known risks of opioid therapy? On the right side of the spread is important information on how to properly convert patients currently on IR oxycodone to OxyContin. Page 15 is also new to the CVA, but consistent with the OxyContin conversion and titration guide. Remind HCPs that OxyContin offers the flexibility of 7 tablet strengths, allowing HCPs to individualize treatment, and that OxyContin is dosed every 12 hours. In addition, OxyContin offers straightforward conversions for patients currently taking IR oxycodone. The conversion chart shows 1-to-1 dosing when converting from IR oxycodone to OxyContin. When discussing initiation of OxyContin in appropriate patients, remind HCPs of the opioid-tolerant doses and the need to monitor patients closely for respiratory depression, especially within the first 24 to 72 hours of initiating therapy and following dosage increases with OxyContin, and to adjust the dosage accordingly. In market research, OxyContin was rated the highest among several brands for familiarity, being easy to convert from an IRO to ERO, having a wide range of strengths available, and being easy to titrate among strengths. Once you have shared how to properly initiate or convert appropriate patients to OxyContin, you might ask, when patients are taking IR oxycodone for around-the-clock chronic pain and aren't receiving adequate pain relief, what do you typically do? Or, how do you counsel a patient taking IR oxycodone on the initiation of an ER opioid like OxyContin? Remember, patients may still need an IR opioid for breakthrough pain. ER does not imply increased efficacy over IR opioids. Always have a balanced discussion when discussing messages and risk information, and ensure the HCP is familiar with the indication, contraindications, and the boxed warning for OxyContin. Once opioid therapy has been initiated, we want to reinforce with HCPs the need to continually reassess the benefits and risks associated with opioid therapy. This new content has been added to remind HCPs to continue opioid therapy only if there's a clinically meaningful improvement that outweighs risks to the patients. Encourage HCPs to evaluate benefits and harms of opioid therapy within 1 to 4 weeks of dose initiation or increase, and every 3 months or more frequently thereafter. Additionally, given some risks of opioids increase with higher doses, HCPs should carefully justify decisions to titrate the OxyContin dose to greater than 60 milligrams total daily dose. HCPs should also evaluate benefits and risks of continued opioid therapy, and if benefits do not outweigh harms of continued therapy, optimize other therapies and lower and/or taper the dose and discontinue the opioid. The CDC guideline has emphasized proactively planning for discontinuation, which we have aligned with by updating the CVA with messaging on how to discontinue opioid therapy if benefits do not outweigh risks, which will be reviewed in an upcoming slide. In addition, you will want to review the important dosage and administration information for OxyContin. The CDC guideline recommends that clinicians use caution when prescribing opioids at any dosage, should carefully reassess evidence of individual benefits and risks when increasing dosage to greater than 50 morphine milligram equivalents per day. Avoid increasing the dosage to greater than 90 morphine milligram equivalents per day, or carefully justify a decision to titrate dosage to greater than 90 morphine milligram equivalents per day. With these in mind, ensure that HCPs are familiar with how to appropriately titrate and discontinue OxyContin. As described in the approved Q&A for reactive use, Purdue's perspective is the greater than 50 and greater than 90 milligrams of morphine equivalent thresholds are not supported by adequate data, but the risk of overdose and death does increase with increasing doses. In addition, the recommendation that an HCP carefully justify individual benefits and risks with increasing opioid doses follows sound medical practice, particularly in situations where patient-specific factors may increase the risk of overdose, such as concomitant use with benzodiazepines. Please note that these perspectives are provided for background only and should not be shared with HCPs. Some powerful questions to engage HCPs are, when you are reassessing your patients with chronic pain, what are some factors that you take into consideration? And how have you worked with your patients to lower or taper their opioid dose when needed? We just discussed the need for HCPs to reevaluate at regular intervals the benefits and risks of continued opioid therapy. The right side of the spread was added to the CVA to review how to properly titrate and discontinue OxyContin therapy. Some key messages to deliver on this page are as follows. Individually titrate OxyContin to a dose that provides adequate analgesia and minimizes adverse reactions. The total daily oxycodone dosage for adults usually can be increased by 25% to 50% of the current total daily dosage each time an increase is clinically indicated. HCPs should periodically reassess a patient's continued need for the use of opioid analgesics as their pain evolves, and discontinue therapy if risks outweigh benefits. If the patient no longer requires opioid therapy or needs to discontinue due to adverse reactions, do not abruptly discontinue OxyContin. Rather, gradually titrate downward to prevent withdrawal symptoms. You may want to ask HCPs this powerful question. How do you determine if your patient is on the appropriate dose of therapy? Or, how do you counsel your patients on their dosing regimen? How often do you see your patients after you've prescribed an ER opioid? Page 18 of the CVA provides the key brand attributes for OxyContin and helps to differentiate OxyContin from other ER opioids. This page will help you protect OxyContin from ER oxycodone competitors with your decile 7 to 10 HCPs. This spread should not be used as the first detail of OxyContin and is not intended for every sales call. Use the table to create brand discussion or summarize key product attributes during a quick call and discuss the risk information on this page in order to have a balanced presentation of attributes and risks. Remember that comparative claims against other products may not be made since we do not have head-to-head data. We chose to summarize the brand's core messages on the last spread based on the following key findings. Managed care cost is a huge determinant in an HCP's decision on which opioid to prescribe. Information overload coupled with HCP's limited time to learn something new requires brand attributes that can break through the clutter. Detail effectiveness can be improved by having longer two-way dialogues. However, it is increasingly difficult to get time with HCPs. This page can help you determine which messaging areas pique the interests of the HCP, giving you the opportunity to engage in a comprehensive, balanced, and conversational sales call. Thank you for taking the time to listen to this training module. We are confident that it has provided you with the key objectives, market research learnings, and powerful questions necessary to create impact with your decile 7 to 10 HCPs.